Yes. Hi, everyone. Welcome. Our next speaker is Dr. Sarah Dry, Chair of the Department of Pathology and Laboratory Medicine at UCLA. Dr. Dry is a pathologist specializing in bone and soft tissue tumors. She trained at Brigham and Women's Hospital and UCLA with fellowships in soft tissue pathology under the renowned Dr. Christopher Fletcher, and GI pathology with Dr. Klaus Lewin. Before becoming chair in 2021, she led UCLA's Translational Pathology Core and Pathology Research Portal, supporting over 400 clinical trials and processing nearly 100,000 samples annually. Her NIH-funded work in biobanking has influenced consent practices that's now used by UCLA Institute of Precision Health, which has enrolled over 200,000 patients. She has published extensively in sarcoma, GI pathology, and biobanking. Her recent work focuses on well-differentiated and dedifferentiated liposarcomas, and she's lead author of the dedifferentiated liposarcoma chapter in the upcoming WHO Classification of Tumours. As chair of the department, she's also led efforts to improve how patients understand their pathology, empowering them to take an active role in their care. Today, she brings a wealth of expertise and compassion to a discussion on sarcoma-specific pathology best practices, her goal being to help you navigate your sarcoma journey or support someone else who is. Welcome, and thank you so much for being here, Dr. Dry.
Thank you so much, Meredith and Julie. Can you hear me and see my screen?
Yes.
Wonderful. Okay, so let me just, sorry. So yes, thank you for that wonderful introduction. I have been a sarcoma subspecialty pathologist for the last 25 years. And I've also, during that time, I've spoken to multiple friends and relatives who have had cancer, and I hope that what I've learned from those discussions and helping them understand their questions will be helpful in the talk that I'm going to provide to you today. And I'm very grateful that this association has allowed us to provide the opportunity to teach you a little bit more about what pathologists do and why our work is important to your care. So what we're going to be focusing on today is tissue-based diagnostics, which is the branch of pathology known as anatomic pathology. But most of you interact with pathology all the time because all of the lab work that is done, your blood-based work, urine-based work, that's all done by the branch of pathology known as clinical pathology. We're best known for our forensic pathology work, which is investigation into the manner of death in public, in TV programs, and that's really what's focused on for pathology. But in fact, most of us very rarely practice forensics. So the pathology report, as you all probably know, is very important to determining your care, both your immediate treatment, but also the care that you're going to receive long-term. How are you going to be followed up? How frequently will you be monitored? What types of monitoring will be done? Very rarely, a pathology report could identify that you have a tumor that may indicate that you and your family members have a risk for a disease that is present within the family. And if that's the case, other family members may want to know about that. And you should know that the pathology report is part of the medical record, and you have a legal right to have a copy of that pathology report at any time you request it. So let's just briefly go through the stages, the steps of what happens after your tissue is taken from either a biopsy or a resection. So the first thing that happens is that the tissue comes into the pathology laboratory and it's given an accession number, it's accession. So that means that the tissue is assigned specifically to you as a patient on that day and for that procedure. And it's provided with this accession number, which is a combination of usually letters and numbers, and it usually includes the year where the specimen was obtained. That accession number is going to be used by you when you request any tissue from that case to be sent out for a second opinion or for any other work to be done on that particular case. Next, the pathologist will do something called a gross examination. A gross examination in this case means that we're only using our eyes. We're not using a microscope to magnify the tissue at all. We describe what we see, what other structures are present, and as part of that, we also determine which parts of the tissue we're going to take to make into slides. We don't typically, for large resections, we don't turn all of that tissue into slides. We only turn a subset of that tissue into slides. The tissue is put into these plastic, what we call blocks, and it's then goes into a machine where the tissue is preserved. And this is a process that usually takes somewhere between 4 hours or overnight, 12 hours. And in that process, not only is the tissue preserved, but also water is removed from the tissue, and paraffin is inserted into the tissue to allow the tissue to be sliced into very nice, thin, clean sections for the pathologist to interpret. Once the pathologist receives the slides, then they might decide to order some additional studies, including immunohistochemistry, fluorescence in situ hybridization, or molecular testing. Once they receive the results of all those tests, the pathologist will make the diagnosis and will finalize and release the report to the clinicians. And in some states, those reports are immediately released to patients as well. Once the final pathology report is released, any tissue that was not used for diagnosis will be destroyed. That usually happens somewhere around 2 to 3 weeks after the final diagnosis is made. And anything here with an accession, with an asterisk, is you'll see that in your pathology report if any of that was done. Long-term pathology laboratories are accredited by a variety of different agencies. The laboratory may choose which agency accredits it. And there's also state laws that apply to pathology departments as well. And both the accrediting agencies and state law set requirements for how long the pathology department needs to store your slides and your blocks. And the reason that we're required to store slides and blocks is so that if you want to access those at a later point in time for your medical care, they are available to you. Once the designated storage period has expired, pathology departments typically destroy those slides and blocks. And just to give you a little sense of how long it takes for each step of this process, these first 4 steps typically take either from less than a day to greater than 4 days. If you have a bone tumor and we need to take sections of the bone, we have to decalcify the bone before we can take those sections, and that can take anywhere from 2 days to 7 days. So for most tissues, this process takes less than 1 day to about 3 days, but for, again, the bone cases, it can be much longer than that. Then this process of the pathologist review of the slides can take anywhere from less than a day to up to 3 weeks. Molecular testing usually takes somewhere around 2 to 3 weeks. Now, some of you may have heard of something called an intraoperative consultation or a frozen section, and I'm just going to explain a little bit about what that is here. This is basically where the pathologist makes an immediate diagnosis during the surgery in order to help the surgeon decide how they are going to approach the surgery, what their next step is. Are they going to remove additional tissue, or have they removed enough tissue and they don't need to do anything further? For most sarcomas, intraoperative frozen sections are not required, but surgeons may ask for those typically to assess the margins of the specimen. They want to make sure that they've removed all of the cancer and they haven't left any of it in your body. Again, and this is something that would be determined by the surgeon. Sometimes before surgery, the surgeon knows that they're going to be asking for a frozen section, so they may tell you that they will do that. Another way that pathologists and radiologists and other clinicians can obtain tissue for a diagnosis is something called fine needle aspiration. In this procedure, instead of taking out a piece of tissue, what we're doing is we're using a needle to aspirate or suck up clumps of cells from a certain organ or a tumor. It's usually done for tumors that are very superficially located in the body, so something that can be felt, a bump, for instance. The advantage of a fine needle aspiration is that it can typically be scheduled much faster than the typical interventional radiology type biopsy. And it can often, because it's scheduled faster, it can often result in a faster diagnosis. Also, at times, pathologists can make the diagnosis on the spot or within a couple of hours of the procedure. So that's the advantage. The disadvantage is that it provides much less tissue than a biopsy. So if the pathologist is going to need to do a lot of additional studies like immunohistochemistry or molecular studies, there may not be enough tissue available for those diagnoses. So what are best practices in sarcoma pathology? Excuse me. Well, first of all, a review by a sarcoma pathologist is essential. As you know, sarcomas are extremely rare, and there are so many different types of sarcomas. And most practicing pathologists see sarcomas as a result very, very rarely. So you really want to make sure that a sarcoma expert has seen your specimen. In Britain, where it's required that all new diagnoses of sarcoma are reviewed by a central expert pathology group, a recent paper from that group found that in 40% of cases, they made a diagnostic change to the diagnosis. And 2/3 of those diagnostic changes were considered to be major changes in diagnosis. And by a major change, this was a change that was going to result in a significant difference in management of that patient. This included cases where something that had been called benign by the outside pathologist was called malignant or a sarcoma by the review experts, or vice versa. Something that had been called a sarcoma on the outside was called benign. It also includes cases where one type of sarcoma was re-diagnosed as a different type of sarcoma by the experts. In contrast to most cancer diagnoses, sarcoma diagnosis really requires correlation with imaging and clinical information. And Dr. Gross, I know, is going to be giving a talk on imaging. We really rely on imaging characteristics very heavily for certain types of sarcomas, particularly bone sarcomas. Now, the specific testing that's done by the pathologist is going to vary quite a bit with tumor type, so there's no best practices here. Sometimes molecular will be performed, sometimes molecular will not be performed. It really just depends. Many people ask if they need a second opinion. I would say that second opinions are less value or less likely to produce a change in diagnosis. If you've been diagnosed with a common sarcoma type, like a well-differentiated, dedifferentiated liposarcoma or a leiomyosarcoma, and that's already been reviewed initially by a sarcoma specialist. If you have a specific type of sarcoma that's characterized by a specific gene rearrangement, like a synovial sarcoma, which is characterized by an SSX SYT gene rearrangement, it's not going to be very helpful to get a second opinion because that is diagnostic of that tumor. If you have had a tumor and you are now experiencing a local recurrence or a metastasis that looks very similar to your primary tumor, a second opinion is probably not going to change that diagnosis. And also, if the diagnosis is what the clinicians expected based on the clinical or imaging features, if they thought you had an osteosarcoma based on imaging features and that's what the pathology report comes back as, that's probably going to provide, a second opinion will probably provide less value to you. But you should consider a second opinion if your primary diagnosis was not reviewed by a sarcoma specialist, as we've just discussed. Also, if your pathology report sounds more descriptive, like a spindle cell sarcoma, without a specific sarcoma subtype, and if your primary care team, your sarcoma team, tells you that their management would change if they had a specific diagnosis, then getting a second opinion would be helpful. I would say that on a lot of biopsy specimens, we often use descriptive terminology because we just don't have a lot of tissue available to examine. There may be a lot of necrosis, there may be a lot of hemorrhage, but that doesn't always mean that having a descriptive diagnosis is less helpful to the surgeon. Many times in those situations, knowing that it is a sarcoma, even if we don't know the specific subtype, is enough for the surgeon to decide to move forward with surgery. So again, descriptive diagnosis is not necessarily bad, but if having a specific diagnosis would change the management, then you should consider a second opinion. If in the pathology report it indicates that a lot of pathologists saw the case, you probably want to get a second opinion. That means that it's a very challenging or very difficult case, and it would be helpful to have another set of eyes by another sarcoma expert look at it. If it's a very rare sarcoma or a very newly described sarcoma, it can be very helpful to have a second opinion performed. If it's newly described, particularly by the person who described it, to make sure that it's similar to what they were describing. And then anytime that the recommended treatment is going to have a long-term adverse effect on your quality of life, for instance, some sort of major surgery, having a second opinion, I think, provides some peace of mind to yourself and to others that it was the right diagnosis and that you underwent the right treatment. In order to request a second opinion, you contact the pathology department where the biopsy surgery occurred or the pathology department that reviewed your slides, and that information is right on the report for you. You will have to tell the pathology department where you want that, where you want your slides sent for the second opinion. If you don't know where you want them sent, you can ask either your clinicians or you can ask the pathologist for some recommendations, and they should be able to provide that. Just know that you may have to pay for the second opinion if the pathology group is competent in their diagnosis and doesn't feel that a second opinion is warranted in order to make a diagnosis. Typically, they will ask that you pay for the second opinion. And it usually takes about a week or two to get the second opinion. So what are the critical components of your pathology report? And anything that's asterisked will influence the management of your case. Again, it's the specific diagnosis, the specific sarcoma type, the grade of tumor. Usually the French grading system is used, also known as the FNC-LCC, but sometimes we just refer to it as either low or high grade. For a resection, the margin status will be important. And the treatment effect, if you've had any pre-surgical treatment, chemotherapy or radiation therapy, knowing how much treatment effect can affect the next steps in the management of your case. Also, any diagnostic molecular information, whether that helps establish the diagnosis or whether there's additional molecular testing done that identifies potential treatments for you. The comment section of the report can also be very important. That's where pathologists will put in other commentary, including commentary about prognosis. There are some sarcomas for which we don't have the histology features alone don't provide good predictive information for us about how that tumor will behave. So we will often put that information in the comment section of the report. The gross section of the report, the gross examination, may be important for clinical trials or for molecular testing considerations. Again, for those of you who have had bone tumors, the decalcification process, the normal decalcification process itself, makes it impossible for us to do molecular testing. We use a different form of decalcification to allow molecular testing on bone samples, so it would be important to know how many blocks underwent that type of testing if you want to have some extensive molecular testing performed in your case. What are some questions that you might want to ask your sarcoma team? Well, first of all, I would ask if the tumor was diagnosed by a sarcoma specialist, and if your team would recommend that you get a second opinion, a second diagnostic opinion. As we talked before, there are certain elements of your report, your pathology report and your tumor that are really going to affect your management. So you might want to specifically ask about those features and ask whether and how those features are going to affect the management that your team is going to recommend. If molecular testing wasn't performed, you might want to ask why that's so, and if your team feels that doing molecular testing could add any value. And finally, many patients are not aware that many academic medical centers and also non-academic medical centers have something that are called multidisciplinary tumor boards, where various specialists get together in a room to discuss individual cancer cases. So that would include surgeons, oncologists, radiologists, pathologists, radiation oncologists, who would all get together to discuss a particular case and come up with recommendations for treatment. That can be extremely helpful. It's very helpful for me sometimes to understand what the concerns are of the clinicians when I have a very small biopsy or not a lot of tissue and I'm trying to make a diagnosis on it. It can also help me express more clearly than a pathology report can to the clinicians taking care of the case what my concerns are, especially again on a small biopsy, whether I think we have enough tissue, whether I think we should have another biopsy, how could a repeat biopsy help us in establishing the diagnosis on the case. So those multidisciplinary tumor boards, because they're an interactive process, are extremely helpful. Let's talk a little bit about clinical trials. Many of you probably have been approached to enroll in clinical trials. This is an excellent opportunity for you to get access to some newer emerging treatments. Most clinical trial sponsors ask the original pathology department to provide tissue in order to ensure that the patient is qualified for enrollment into the trial. In other words, they have the tumor type that's being studied, or they have particular features of the tumor that are required for this trial. When they make those requests, they ask us typically for an entire paraffin block, or they ask us for 10 to 25 unstained slides. What's really needed for enrollment is often just a fraction of that. Often to do the testing that's needed for enrollment is going to take less than 5 unstained slides. And it becomes complicated because as people seek many second opinions, they typically enroll in multiple different clinical trials. But sometimes you might only have one block that has tumor in it. And the number of possible slides that are present within a block really varies quite a bit depending on how much tissue is in the block, how small or large the biopsy was, how much other testing has been done previously in order to make the diagnosis. And it can range from fewer than 25 slides to over 100 slides. So if you are enrolled in 4 different clinical trials, or trying to enroll in 4 different clinical trials, and all of them want a block or 25 unstained slides, you can see how the tissue that's in that block could disappear, or what we call get exhausted very quickly. In other words, we use all of the tissue that was in that block for these requests. Unfortunately, patients don't qualify for all clinical trials that they try to enroll in, but it's very difficult once the tissue has been sent to a sponsor to get it back. So, you know, if your material is exhausted, there are some limited options for you in that case. You might need to have a rebiopsy, which is not a small undertaking. Or sometimes you might be able to use other samples, like if you had a biopsy of something a couple of months earlier that was your tumor, they may be able to use that, but that's not always the case. So, you know, I would just say that, you know, you keeping a tissue inventory and understanding where your tissue is, how much tissue you have, and how you can allocate that could be very helpful. Also thinking really carefully about what are your priorities for these various clinical trials is very helpful, because once you've signed the paperwork enrolling in the clinical trial, I get a request, the pathology department gets a request to release that tissue. There's typically not a lot of further conversation with the patient about what their priorities are. I have, in some situations where there's been very limited tissue, I have called up patients to find out what their priorities were. But again, this is just, it's a great benefit to have all these clinical trials, but it can also create this other stress on your tissue supplies that you should know about. And that is the end of my talk for now. I'd be happy to answer any questions. I really wanted to thank Julie and Meredith for all the helpful discussions as I was preparing this talk, and I thank you all for your attention and for any questions you might have.
Great. Thank you so much. Thank you so much. Sorry, my dog. Sorry, everyone. Thank you so much, Dr. Dry. That was so informative and great. It looks like we have about 5 minutes. So I'm going to look at the questions, and there might be some, if you have the time to go in there and answer them if we don't get to them. And anyway, let's see. So the first one looks like more of a, you know, wish I would have known that, you know, 18 years ago, I had a surgery for a rare tumor. At the time, no one told me to preserve the tissue. Yeah, so I think it's about that, like ask for your surgery or biopsy, make sure your tumor is saved. And so, and I know with my experience with my son, like his is gone. Like no one was, you know, like it's amazing to me that it's just disposed of and that you're not even contacted. And I definitely think there's a lot of um, information or education in this area that you just don't get, you know. So I don't know if you have any thoughts about that. Like now you have nothing left, you know.
In terms of what can you do?
Yeah, yeah.
Yeah. Most of the time, the decisions that are going to be made for your management are going to be made based on your most recent tumor. So if you have a recurrence of tumor and it's large enough to get a sample of that, that's where the decisions are going to be made, because typically the tumor evolves over time. And particularly if it's metastasized, it's taken on additional characteristics. And so they want to test that tissue because they want to be attacking the features that are defining that particular tissue, the metastatic tissue, not the original tissue. So I would say that not all hope is lost,
Right.
and that, you know, you can still access that.
Yeah, no, that's great. I guess my other question that kind of follows up to that, it is that, is there a protocol within pathology for sarcoma where you do relook, like, so assuming you have that original tissue, is that looked at? Like I've never heard about a protocol of that. Like, is there a protocol to, like, oh, now it's been this many years, do we look at it? Like in my my son's was more of the descriptive type, right? So anyway, I'm just curious if, because I know things change, right, in the medical field, and like something could be diagnosed as one thing and then change. So I'm just curious if there's any type of protocol for that.
There's no particular protocol for that. As you can imagine, it would be quite complex for us to keep track of all those cases and all the different changes that are happening. But what I would say is that, if somebody recurs with a tumor, let's say, and it doesn't look to me like what the original diagnosis was, or it's behaving in a way that doesn't make sense based on the diagnosis and how those tumors usually behave. I personally will often go back, if we have the pathology here, I will go back and I will look at prior samples to make sure that I agree with the original diagnosis, or that the original diagnosis, as you said, Meredith, hasn't changed or evolved over time, and we would be using different terminology now. But there's no set protocols for that. That's a practice that most sarcoma experts would follow based on my conversations with people.
Okay.
And I did, Meredith, there was a question about a standard storage period for tissue. I just wanted to address that. So
yeah, great.
it depends based on the accreditation agency for the laboratory, and it also depends based on state laws. So it ranges from 2 to 10 years or more. And there are some institutions that keep their tissues in their blocks forever, their slides in their blocks forever, but most will discard because it's a storage issue.
And so there's no like right of the patient then to be notified, we're disposing of this, because
That's correct.
Yeah. Okay.
Yeah, and that's based in part on, what we do is we look at how frequently are these samples requested after a certain period of time. We get a lot of requests within the first 2 years, but after 5 years, the number of requests really goes down quite substantially.
Okay. Yeah. No, that's great. I just think to be more educated, talking about advocacy, and to be more educated and to learn about the different storage because there are other storage options outside of the facility. Because and this was another question, we'll finish up here. The I think it's like if it was the surgery was done at a certain institution and a block or something sent out, is that that tumor always or block always sent back to the original institution?
So it's supposed to be sent back.
Okay.
Again, we have a lot of requests for these send-outs. Our institution, our policy is that we don't send the block out. We only will send out unstained slides because we're legally responsible and responsible by our accreditation agency to keep track of the blocks. But other people will send out blocks. The requirement is that you have at least one representative block on site. So some will send out other blocks. But that becomes problematic because, again, when people are asking to be involved in a lot of clinical trials, once the blocks go, then you don't have a lot of tissue left in order to provide samples to other people. I'm not sure if that answered your question, Meredith.
Yeah, no, I think so. Yeah. Okay, well, I know there's a lot of questions in there. If you have time, if not, we will, follow up later. But if you're able to just go in the chat and answer any of those questions, thank you so much. This was such a great presentation, and thanks everyone for the questions. And